uh, we will move on to the next lecture, which is actually Dr. Shi. Angela Shi is rejoining us after her meeting and is going to talk about cholestatic liver disorders.
Thank you, John. This is definitely much more interesting than meetings. So, all right. All right, so I think we're reaching towards the end of your liver morning today. So this is your third medical liver lecture, which is going to be on the diagnostic approach to cholestatic disorders. All right, and I have no disclosures. All right, so a brief outline of what we're going to be discussing in the next half an hour. So we're going to talk about kind of the patterns of cholestasis that we see and just make sure the terminology that we're using when we describe cholestatic patterns is the same, because I know there's a lot of different words that people use, and I just want to make sure that we're on the same nomenclature as we move forward in this talk. Next is going to be the clinical and histologic features of acute and chronic cholangiopathies. And lastly, talking about some histologic mimics of autoimmune biliary disease that pathologists need to consider as they evaluate these cholestatic biopsies. All right, so I just want to start by talking about what our role is in evaluating these cholestatic liver biopsies. Similar to when we were talking about acute hepatitis biopsies, we aren't always able to specifically classify what is going on, but there are categories that are important to communicate to our clinical colleagues to provide information to them that would be helpful for their treatment decision making. So one would be the presence of an acute or chronic biliary process, and in many cases will require some level of clinical correlation. Next would be to suggest some possible etiologies if it's not clear exactly what it is. Third would be to evaluate the severity of liver damage. So that would include the extent of biliary epithelial injury, the extent of ductopenia that might be present, or any kind of portal fibrosis to suggest a chronic process. And lastly would be evaluate for a second process, in particular, whether or not there might be a hepatitic component to suggest the possibility of overlap syndrome. All right. Sorry, there we go. All right, so the first thing that I wanted to go over is just the nomenclature of our cholestatic findings. So here I think we can appreciate that there are these yellow, green, well-formed globules that are present within the canalicular spaces. This is present scattered throughout this image. And so that is what we refer to as canalicular cholestasis. Now, in some cases, you can see just canalicular cholestasis without any evidence of a ton of hepatocyte injury or any reaction around it. And in those cases, we can classify that kind of finding as a simple cholestasis or a bland cholestasis, which comes with its own kind of differential. But in other cases, we do actually find evidence that there is ongoing injury to hepatocytes as a result of this accumulation of bile salts. And so in this case, we are seeing numerous small aggregates of Kupffer cells, which are pigmented with bile salts. And in addition to that, in this background, we can see this change in the cytoplasm of these hepatocytes in a form that we refer to as feathery degeneration. So feathery degeneration here we're classifying as this change of this as rarefaction and fine vacuolization, foamy type cytoplasmic change in these hepatocytes, which is distinctly different from that densely eosinophilic granular cytoplasm of your background hepatocytes. So that's the most classic form of feathery degeneration, which is oftentimes associated with toxic injury due to the accumulation of bile salts. But there is a spectrum that we can see in feathery degeneration. And in some cases, you can actually see almost more of a ballooning type morphology. So this would be an example of that, where you're seeing in a large size on a ballooned hepatocyte here with extensive, more like vacuolated kind of cytoplasmic clearing, maybe even a hint of some Mallory hyaline. But if you look at the background, you'll see that the background is in fact cholestatic with bile plugs and is not really a steatotic type picture. And so all of this together would put this morphology in is a similar kind of morphology of feathery degeneration, suggesting some sort of cholestatic injury to these hepatocytes. I also want to point out this bile duct here, which is a little bit dilated and ectatic, but it does also have an inspissated bile plug within it. And so that's a form that we will refer to as cholangicular cholestasis, which also in certain cases can bring up its own differential as well. The other thing that we want to look for as we're evaluating these cholestatic liver biopsies is making sure that we understand what's going on with our portal tracts. And in particular, we want to take a careful look at our bile ducts. So in this particular portal tract, I have two native bile duct profiles here, and you can see that they show clear evidence of biliary epithelial injury. Now, how biliary epithelial injury is diagnosed is by a couple of different histologic features. Here you can see many of them. So you can see some nuclear hyperchromasia within the biliary epithelium. You can also see some nuclear disarray where these nuclei are starting to overlap and also showing areas of nuclear dropout. There is some evidence that there might be some cytoplasmic vacuolization here within this biliary epithelium. And lastly, and most tellingly in this case, is these infiltrating lymphocytes within the biliary epithelium causing an immune-mediated damage. And so you don't have to see all of these features to officially classify a biliary epithelial injury, but obviously the more you see and the more prominent the findings do you see, the more confident you are that this biliary epithelial injury is a pathologic process as opposed to a secondary injury due to portal inflammation in the nearby vicinity. All right, so now we're going to move on to our first case, which is a 70-year-old man who presents with acute abdominal pain, nausea, and emesis. His imaging study showed biliary stones and duct dilation that clinically was consistent with an acute biliary obstruction. His LFT findings show here, ALT, AST were only minimally elevated, whereas the alkaline phosphatase showed an acute elevation to 620. So in this patient's biopsy, we saw a number of really marked portal-based findings, all of which point to the triad that we would expect for an acute biliary obstruction. And so let me go over what those features are. So one is that this portal tract is markedly expanded beyond the size of what you would expect for a typical portal tract, and it's expanded by a marked edematous type process. So oftentimes this will show a myxoid type discoloration and will also show a looseness to the mesenchyme within this portal tract to suggest that there's an edematous process going on. Second would be this mixed portal inflammatory infiltrate. So not only are there mononuclear cells within here, but there also are readily identified neutrophils as well as some eosinophils. So this mixed portal inflammatory infiltrate is also consistent with the biliary obstruction. And lastly would be some biliary epithelial injury, but more than that is that there's also evidence of a ductal reaction. So this increase in the number of bile duct profiles, oftentimes irregular and somewhat poorly formed, is also part of this process. So in the setting of an acute biliary obstruction, another finding that you might see is what we refer to as a bile infarct. So that is this area right here, where you can really see that there is a replacement of a small area of hepatocytes by foamy histiocytes. In this case, this happens to be adjacent to the portal tract, but it doesn't always have to be. But in the setting of extensive cholestasis, in particular, when you have an acute biliary obstruction, you can definitely see small nodules like this where the parenchyma has necrosed and has been replaced by these foamy macrophages. So when we talk about an acute cholestatic liver, there's a couple of etiologies that we want to think about. So in this case, we've kind of discussed these acute biliary obstructive findings of this triad of a mixed portal inflammatory infiltrated ductal reaction and marked portal edema. Other things that you might think about would be a drug reaction. Now, drug reactions come with a variety of histologic patterns, including in a biliary obstructive type pattern, but more commonly more of a simple cholestatic or cholestatic hepatitis. Ischemia is something that can also cause an acute cholestatic liver, as well as some more specific etiologies such as cholestasis at pregnancy, which typically is more of a bland cholestasis, and paraneoplastic syndromes. There are also some inherited disorders that I won't mention here. One thing I do want to mention is that it is important to keep in mind that decompensated liver failure can also present with an acute cholestatic type process, but in this case, this would be an acute on chronic process, and you likely would see evidence of cirrhosis or advanced liver disease from other etiologies in the background. So going back to this case, certainly it had histologic features of an acute biliary obstruction, but one thing that I do want to point out is that the number of neutrophils that you see in this portal inflammatory infiltrate is actually a little bit more than you would typically see for your run-of-the-mill biliary obstruction, which raises the possibility of whether or not there's actually an ascending cholangitis here on top of the acute biliary obstruction. And that was in fact the case for this patient, in that this patient not only had an acute biliary obstruction, but also ended up growing out both E. coli and Klebsiella consistent with his ascending cholangitis. Other things that I want to mention as we wrap up this discussion is I mentioned a little bit about cholangiolar cholestasis. Now, cholangiolar cholestasis is a nonspecific finding. However, if you see a lot of it, there are some things that might raise up on the differential diagnosis. Things like sepsis and critical illness can cause more extensive cholangiolar cholestasis. Paraneoplastic syndrome has been described to do this, and TPN effects is a particular manifestation of kind of drug kind of manifestations is also something that has been associated. But I do want to emphasize that cholangiolar cholestasis as a pattern is not particularly specific. Another pattern that I want to mention, because we kind of talked about it, is this particular case is a different case that seems to have more canalicular cholestasis, but I would argue that it has fewer parenchymal-based findings in the background, not so much in the way of feathery degeneration, not so many serolated macrophages and Kupffer cells that are pigmented in the background. So this is a little bit more of a simple cholestatic type process if we were to go on the histology alone. And so when we see that with minimal lobular changes in the background, really the first thing that we think about is drug effect, because that's the most common, but we would also think about paraneoplastic syndrome or cholestasis in pregnancy in the correct clinical contexts. All right, moving on to case 2. So this is a 20-year-old female with a history of DRESS syndrome, which was secondary to her use of lamotrigine, and she had a persistently elevated bilirubin jaundice for the past 3 months. Her recent MRCP was negative for obstruction, and you can see here her LFT findings. Her ALT, AST were mildly elevated, alkaline phosphatase again slightly elevated, but it was really her total bilirubin that showed a really marked elevation and was the explanation for her jaundice. So most of her liver biopsy actually shows some pretty mild nonspecific findings. So here we can see a level of canalicular cholestasis here without a ton of evidence of feathery degeneration or injury in the background. But there were also other areas of her biopsy that showed a little bit more evidence of that injury. Here you can see, in addition to the canalicular cholestasis that's present, numerous Kupffer cells that are pigmented and accumulating bile salts. Next, we wanted to take a closer look at our portal tracts. So these are 2 examples of her portal tracts that we saw in this biopsy. In both of these, there's a non-specific portal inflammatory infiltrate, but more tellingly is that there is mild evidence of some biliary epithelial injury here, a little bit in nuclear disarray. It's nothing hugely significant, but it certainly is there in both of these portal tracts. However, the most telling finding was in our other portal tracts. So these are 2 additional portal tracts which actually show evidence of bile duct loss. So you can see here in this portal tract, we have this portal vein, we have the small hepatic arteriole, but we have no evidence of a native bile duct profile within this structure. And same on the right-hand side, no evidence of that native bile duct profile. And so when we did a formal count on this biopsy, we actually found that about 2/3 of the portal tracts were missing a native bile duct, which would be consistent with the descriptive diagnosis of ductopenia. If it is challenging, and sometimes it is, to identify whether or not these native bile ducts are present, it can sometimes be very helpful to do a keratin 7 stain. So keratin 7, as we know, will strongly highlight biliary epithelium. So any native bile ducts will be strongly positive and can help you identify those native bile ducts. But the other thing that is very helpful about a keratin 7 stain is it also will highlight periportal peribiliary metaplasia. And so this is a phenomenon that happens as a transformation of stem cells at the interface, in which these stem cells, because due to some level of chronic injury, are starting to develop some sort of biliary type keratin phenotype. And so they can, in a very weak type pattern, start being highlighted by CK7. And what that does is that it can highlight where your native portal tracts are, so that you can more readily identify whether or not there's bile duct loss. And so you can see that on the right-hand side, where maybe if you're screening through this biopsy, you might pass over these areas as potentially other structures, but this peribiliary metaplasia really does identify these as portal tracts that should be having native bile duct structure, so we can have a lot more confidence that in many of these portal tracts, those native bile ducts are in fact lost. There was also a copper stain that was done on this case. This copper stain happened to be negative. So copper accumulation in periportal hepatocytes is something that you can see in chronic cholangiopathies. But because of the kind of issues with our rhodamine stain, having a positive copper stain is helpful. Having a negative copper stain, unfortunately, is not particularly helpful. All right, so when we talk about ductopenia, which again is defined as greater than 50% native duct loss on a biopsy, and in these cases, you really want to see at least 12 portal tracts to be able to adequately assess for this. The first thing that we would think about is a chronic cholangiopathy, and this would include any of your autoimmune cholangiopathies, PBB, PBC, PSC, and many others. But it's important to realize also that any chronic injury to bile ducts can also result in bile duct loss. So this next, what I want to talk about is vanishing bile duct syndrome, which can be acquired, but is often secondary to drug reaction. That was actually the case for case number 2 in this patient. Lamotrigine has rarely been described to present with a vanishing bile duct syndrome, and that was in fact the etiology for this patient's ductopenia. Paraneoplastic syndrome is something that can cause ductopenia, sarcoidosis, as well as other developmental or disorders like Alagille syndrome. And in very specific scenarios, of course, liver transplants and bone marrow transplants can also show ductopenia as evidence of chronic injury. So to talk about some of these other reasons for ductopenia, this was a patient with sarcoidosis, known sarcoidosis with mediastinal lymphadenopathy, diagnosed previously on hilar nodes. But you can see here that we have a portal tract here with this non-necrotizing granuloma present within this portal tract. And the right-hand side, we can see evidence of this portal tract with no evidence of a native bile duct. So it can be somewhat challenging if we just had the liver biopsy to know that this was sarcoidosis, even though that granuloma on the left-hand side does look somewhat sarcoid-like. But having that clinical history of knowing that this is a patient with an established history of sarcoidosis certainly helps us feel more comfortable about attributing duct loss to that systemic process. This is another example. You can see this cholestatic change in the background. And again, what is striking here is that in these portal tracts, we have marked absence of your native bile ducts. Interestingly here, you are also not seeing any evidence of any ductal reaction here. So this happens to be a case of Alagille syndrome in someone who had actually been transplanted and also presented as an adult. This was a non-syndromic patient and didn't have any other kind of associated syndromic kind of manifestations of his Alagille syndrome. All right, moving on to case number 3. So this is a 46-year-old woman who presents with pruritus and increased cholesterol. She had an elevated alkaline phosphatase for at least 3 years. Her ANA was negative and her AMA was positive at 1 to 160. So on low power, this patient's biopsy is already markedly abnormal. We can see that the abnormality really lies in this incredibly dense inflammatory aggregate, inflammatory infiltrate that is involving the portal tracts in a very patchy manner. If we look in the background parenchyma, we see a little bit of steatosis, but not really a whole lot else to catch our eye from low power. When we go on higher power to some of these portal tracts, we again see that dense mononuclear inflammatory infiltrate that again is very well bounded. You can see that it is very well confined to the portal tracts with very little infiltration into the surrounding parenchyma. And then of course, the most diagnostic finding, of course, is this granulomatous inflammation that is centered on a heavily injured bile duct. And so this, of course, is the morphology that we would expect for a florid duct lesion, which in the setting of someone with a chronic cholangiopathy would be consistent with primary biliary cholangitis. Now, here I have a table summarizing some of the clinical features of primary biliary cholangitis. It's oftentimes more middle-aged women with a history of autoimmune disorders that tends to present with this disease. But one thing that I do want to mention, and I think this is something that Dr. Pratt had kind of mentioned this morning, is that the diagnostic criteria for PBC depends on 3 different categories: biochemical evidence of that alkaline phosphatase being increased over 6 months, the serologic evidence of a positive AMA, and histologic evidence of an immune-mediated destruction of bile ducts, most commonly with floor duct lesions. Now, as he mentioned, as Dr. Pratt mentions this morning, the expert consensus has really suggested that this diagnosis can be made on the presence of only 2 of these 3 criteria. So as you can see, we no longer actually need histology evidence of PBC to make this diagnosis from a clinical context. And so what that means for us is that oftentimes when we see the biopsy, the question is actually more about what their baseline disease is, what their fibrosis status is, or it is a clinical scenario in which these other diagnostic criteria are not met. So this is another example of what these floor duct lesions can look like. Again, this dense portal mononuclear inflammatory infiltrate. Here we still have a histiocytic inflammatory infiltrate surrounding these injured bile ducts, but I would argue that perhaps this granuloma is not as well developed as it was in the previous case. That's still okay. You are still seeing an immune-mediated destruction of your bile ducts, which would still be classified and consistent with a PBC. This is another example which shows even less of that granulomatous inflammation. Again, you can barely even see that histiocytic aggregate here, but given the density of this inflammatory infiltrate and a clear immune-mediated destruction of this bile duct, this would still be consistent with PBC as long as all of the other clinical parameters fit as well. Histologic staging of PBC, we typically at our institution use the Schuer stage, and it progresses from 1 through 4, where stage 3 is bridging fibrosis and stage 4 is established cirrhosis. The only thing I want to mention here is that classic histologic features of PBC are oftentimes no longer present at the later stages. As you are starting to become ductopenic, you can oftentimes no longer see that immune-mediated destruction that we so depend on to make this diagnosis. This is an example of a later stage PBC. You can see these bands of bridging fibrosis that are confirmed on trichrome stain. But in addition to that, you can see these aggregates of lymphoid cells that are present residually within these bands of fibrosis. And if we go on higher power here, we can see that these small aggregates of lymphoid cells are present in these ductopenic portal tracts, likely marking the area where a prior native bile duct had previously been destroyed. And so all you oftentimes will see in these settings of more advanced fibrosis is just these lymphoid aggregates marking where a previous bile duct had been. Moving on to case number 4. So this is a 19-year-old man with an established history of ulcerative colitis who also had an elevated alkaline phosphatase for 2 years. But for him, his ERCP and MRCP both showed abnormal strictures and beating of the bile ducts. Now, I'm no radiologist, but I think that we can all very clearly appreciate in this beautiful image here that there is, in fact, a huge number of strictures that are present within this image. And of course, on histology, we're going to just talk about the classic finding, which would be the periductal onion skin fibrosis that we see in this image, this concentric kind of lamellated collagen deposition that's encircling these small to medium-sized bile ducts. Now, of course, having those features would make a diagnosis of primary sclerosing cholangitis. Again, I have a table of the clinical features here. Slightly more common in men, but can happen at any age, a strong association with IBD. But one thing that I want to talk about is how we make this diagnosis. Because again, we can have biochemical evidence, radiographic evidence, and histologic evidence. But when we talk about histologic evidence for PSC, we have to remember that the histologic findings that we see depend hugely on the stage of the fibrotic lesions as well as the size of the compromised ducts. So not all PSC patients will have effective ducts of the same caliber. And knowing what caliber ducts are being affected can really drive the histology that we expect to see on our biopsies. So this is an example of someone with PSC. So here you can see features that are very consistent with a large duct obstruction. So you can see the periportal, the portal edema, the mixed inflammatory infiltrate, some element of a ductal reaction. And so this was the manifestation in someone who had a large duct PSC, someone who on MRCP had clear evidence of a large duct stricture, which lends itself well to this histologic manifestation of a large duct obstructive type morphology. On the other hand, when you don't have a large duct obstruction, the findings can get a little bit more subtle. So this is another example of PSC with more of a small duct type involvement. Here you can see again a little bit of suggestion of a periportal fibrosis, but more tellingly is this some element of kind of a biliary epithelial injury, a little bit of nuclear disarray, a little bit of nuclear hyperchromasia. The findings can get even more subtle. This is another example of a small duct PSC where here you can see some nuclear dropout against a nuclear disarray. Maybe these bile ducts are looking a little bit shriveled, a little bit atrophic. But again, in these small duct PSC findings, you oftentimes will not see those classic onion skin fibrosis features, but instead you commonly will see just these small subtle findings indicative of perhaps some element of biliary epithelial injury. So in these cases with subtle findings, maybe some indeterminate radiographic findings, how would we support a diagnosis of chronic cholangiopathy? Well, there's a couple things we can do. And one of the things we can do is go back to our stains. So CK7 can be helpful here in highlighting that ductal reaction. It can also try to highlight some element of a ductopenia if that's present. Both of those together could imply some sort of chronic biliary process. Another thing we can do is our copper stain. So as I mentioned before, copper is excreted through bile. So if you have a problem of bile excretion, one of the things that can happen secondarily is accumulation of copper in your periportal hepatocytes. But again, your rhodamine stain actually only picks up specific oxidation states of copper. So having it positive, as in this case, would be suggestive of chronic cholangiopathy. A negative copper stain, unfortunately, is not helpful. The last thing that we can look at, because we are trying to support a chronic cholangiopathy, is that we would want to look for features of a chronic process. And so a chronic process would mean some sort of portal-based fibrosis that is evolving into a bridging fibrosis. And so that was the case for this case, where you can see here these portal tracts, a portal tract here, which is starting to bridge underneath. And so that kind of portal-based expansion and fibrosis, again, in context with the CK7 and copper stain, would help provide further histologic evidence for chronic cholangiopathy, which again, in the right clinical scenario, could represent some sort of small duct PSC. Histologic staging of PSC is the Ludwig stage, which is very similar to the Schur stage. And really all I want to talk about is the stage 3 and stage 4, where we have bridging fibrosis and established cirrhosis. And this is an example of an advanced stage. Again, you can see this portal expansion in the beginnings of this bridging fibrosis with early nodularity, consistent with a more advanced stage of fibrosis. This is a chart just comparing some of the diagnostic features of PBC and PSC. We don't have to go through it in detail, but one of the things that I do want to mention and continue to discuss is that chronic cholangiopathies can sometimes have very similar morphologies and can actually mimic other disease processes. So some of those other disease processes we previously mentioned, so one would be sarcoidosis. I know we've kind of discussed this already, but I wanted to discuss this particularly in the context of the differential of PBC, which oftentimes comes up given that there's granulomas within this portal tract and the fact that there might be ductopenia. So one of the things that I think can be helpful in distinguishing these two entities is the fact that this granulomatous process in this portal tract is not duct-centric. And you have to remember that the defining feature of PBC is a duct-centric granulomatous lesion. So the fact that this granuloma is a little bit separate from this bile duct, these bile ducts really, for large part, look completely uninjured and unbothered by the process, perhaps in the right clinical context might make you think a little bit more about sarcoid. But again, of course, the clinical context and the clinical history is incredibly important here. Another potential issue that we can see in these cases is a case like this. So here we see in this portal tract an incredibly dense mononuclear inflammatory infiltrate. This was a biopsy that actually was originally called a chronic hepatitis because of this inflammatory infiltrate that's here, but it actually ended up being a chronic cholangiopathy. And I do think that there are some histologic features here that can be quite helpful to us as we're trying to make that distinction. So one is that if we look at the interface here, we see that this inflammatory infiltrate, again, shows very little interest involving these hepatocytes. There's no real evidence of any injury at the interface. There's no huge amount of infiltrate infiltration of this inflammatory infiltrate out into the surrounding hepatocytes. So really, you get this impression that this inflammatory infiltrate is not so much interested as a hepatitic component, but maybe is a little bit more confined as a portal-based process. And when in fact we take a closer look here, we actually see that there is evidence of some biliary epithelial injury in the setting, in the background of this mononuclear inflammatory infiltrate, all kind of suggesting perhaps that this inflammatory infiltrate is a little bit more interested in injuring bile ducts than it is in the hepatitic component. Copper accumulation, of course, can also be helpful in trying to sort of tease out whether or not this is a chronic cholangiopathy. And the last thing that I want to mention is this, whether or not the patient has appropriate biochemistry. So if we're talking about a chronic hepatitic process, then really we're kind of talking about a process that really is presenting a little bit more as a hepatitic kind of LFT pattern, as opposed to if we're talking about a cholangiopathy, then we really would expect more cholestatic LFTs with a more significantly elevated alkaline phosphatase. Other issues that we see here, so this is an example again of a large duct obstruction with a biliary, with periportal, portal edema, a ductal reaction, and some bile infarcts here. You can see radiographically the stricturing, but instead this is actually not a primary sclerosing cholangitis, this is a secondary sclerosing cholangitis, because this is a patient who had been critically ill with COVID-19 and eventually manifested with these histologic findings. So something to be aware of as you're differentiating between a primary and secondary sclerosing cholangitis. Lastly, I wanted to talk about plasma cells a little bit. So this happens to be a case of PBC that has a huge number of plasma cells. So I know that as pathologists, we oftentimes are have a knee-jerk reaction to look at plasma cells and think about an autoimmune hepatitis. But in this case, we have to remember that PBC can also have a number of plasma cells. Again, your hint here is that there's biliary epithelial injury, not a hepatitic component. So these are the pitfalls that we've really mostly discussed. I want to just spend one more slide talking about under recognition of a second process, because of course I can't talk about cholangiopathies without at least mentioning overlap syndrome. So I don't have time to go over the details of the diagnosis of overlap syndrome, but suffice to say that it requires at least a moderate interface activity of autoimmune hepatitis, as well as histologic or clinical evidence of a chronic cholangiopathy. As pathologists, it's important for us to remember that not all patients present with both components simultaneously. So it is very common for us to see a biopsy in which one component is established, but you are unsure about that second component. And in those cases, I think in general, it is the better part of valor for us to be a little bit careful and cautious in making this diagnosis. We oftentimes will make the diagnosis that's definitive and then suggest rebiopsy after treatment of that component to reevaluate at a later time. Because if a patient truly has overlap syndrome, they will manifest wholeheartedly at some point in time. So that brings me to our conclusions of biliary disease, which depends on a lot of clinical correlation. We talked about some of the issues that we need to report on in our pathology reports, as well as some of our pitfalls. And with that, I think I will leave it at that. And thank you for your attention.
Great, thank you. So I think maybe just do a few quick questions before we go to the next session. One is, I guess you did touch on this a lot, but relating to the use of the copper stain in these cases, I guess you again went into great detail, but maybe just make one further comment about how often do you get that stain, and what is your sort of practice with ordering it?
Yeah, sure. It's a good question because sometimes it's helpful and sometimes it's not. I will admit I get CK7 and copper stains quite often when there is a clinical question of a chronic cholangiopathy. I will say that the copper stain more often than not is not useful because it commonly will come back negative, and so then it's kind of uninformative. But in those certain cases where it does come back positive and there's a strong clinical history and a suspicion for it, then I do find it helpful in those situations to further suggest a chronic cholangiopathy. Oftentimes our clinical colleagues may not even necessarily need a distinct diagnosis. They kind of just want to know that there's a chronic biliary process that's ongoing. And oftentimes that can be enough for them to kind of decide treatment from that standpoint. So I do use it quite often, but I will be honest that it's not always helpful.
Great, thank you. And yeah, I think our lab has a stain that works fairly well. I over my career, I have worked in institutions where it was not really a validated stain, so it wasn't even a consideration. And I imagine many in the audience are in the same boat. All right, let's move on. Thank you very much, Angela.